Hello, and thank you for joining us for Suicide Death Investigations, Psychological Autopsy, and Connections to SFR. Before we get started, I'd like to remind everyone of the requirements for receiving continuing education credits or a certificate of attendance. At the end of this session, I'll read off a 4-digit code, which will need to be recorded on the CE certificate for today's event. You'll find additional instructions on the front of the CE certificate available at the registration table. If you did not pick up a copy when you checked in this morning, I have a few extra copies with me. Please be sure to complete the post-event survey before you leave today. The QR code for the survey is on the back of the CE certificate. Now let's welcome Dallas Allen and Austin Lucas to begin their presentation. We'll let them introduce themselves to get started.
Good afternoon, everybody. I do want to preface, I do apologize if you've already heard me talk a couple times today. You'll probably hear some repeats, some things that you've already heard before. And I touched on my position a little bit throughout all of those just because it's a big part of the process that we and how we handle the SFR in Franklin County. But I'm just going to go a little bit more in depth on what my position is and kind of what my daily operations are at the coroner's office. So my name is Dallas Allen. I am the Suicide Investigations and Postvention Specialist at the Franklin County Coroner's Office. Just to talk a little bit about myself, just as an introduction. So I received my bachelor's degree in criminal justice from Muskingum University, and I graduated in 2017. Since graduation, most of my career background is in adolescent mental health. So I spent some time at a residential facility for young women between the ages of 12 and 17. I was a program manager where I helped my clients develop coping strategies that were needed due to lifelong trauma related to physical, emotional, as well as sexual abuse. Then I also spent some time at the Franklin County Juvenile Court as a founding member of the Misdemeanor Services Program within our court. So essentially our approach was working with low risk but high need youth and trying to connect them with resources that can divert them from further involvement with the criminal justice system. Regarding my position and title that I have now, so I'm actually the first person to hold this title within a medical legal office in the nation. I am no longer the only. We've had some additional individuals pop up that are doing things similar to what I'm doing, which has been a goal of mine since I started. So I'm really excited to see how this position can impact other communities as well. So since July of 2021, when I took on this role, I have completed hundreds of psychosocial investigations and interviews with friends and family who have lost a loved one to suicide. And most importantly, as a suicide loss survivor myself, I've connected with over 700, almost 750 individuals to grief guidance and resources that are intended to help them with life after a suicide loss. Again, I am part forensic investigator, but most importantly for me, making sure that I'm able to walk alongside with the family who have just experienced a type of grief that is just honestly unexplainable. It's a very intense type of grief, and so being able to be there on scene and moving forward with that family member is something that I hold very dearly to my heart, and is one of the best things that I get to do, as it's a feeling that you feel very, very alone, and so being able to be in their corner is really important to me. As I go through this, I'm going to start a little bit just by talking about the overall roles of my position, and then I'll actually shift and speak a little bit more about my day-to-day operations, things that I'm doing every time I come into the office. So as a suicide specialist, I have two primary functions. The first function is going to be interviewing those suicide loss survivors for that psychosocial history of the decedent. And then again, like I mentioned, that second function is going to be providing those loved ones with grief resources and guidance. An important component of my position is to bring a unique perspective to the investigative unit and the rest of the coroner's team. Although I do complete that forensic investigative work that I was talking about, I'm going to be focusing more on that decedent, understanding who that decedent was, understanding what their life experience is and the things that have impacted their life path on a deeper level. Our death investigators have a primary function of investigating that death scene, collecting evidence that will help the pathologist with determining cause and manner of death. And although I do help with both of those, the information that I'm collecting through my psychosocial investigation is going to go a really long way in determining that manner of death specifically. Having an accurate certification of death is extremely important, not only for in the world of suicide, but all other manners as well. So if we have accurate certifications of death, that means our data sets are also going to be accurate. So that means the number that we're reporting out to the community and stakeholders is accurate and honest, and therefore we would have more buy-in if we have the appropriate number. If that's suicide or if that's overdose, we want to make sure that all of those are accurate. And so that deep dive information and understanding where the decedent was mentally leading up to their death is extremely important for that final manner of death. In addition to helping the pathologist with that information is also going to be very important when it comes to identifying trends, seeing things that are happening in our communities and almost close to as real time as possible. In other circumstances or in other communities, a lot of times you have to wait for the end of the year, collect all of that information, and then try to create data sets and actually prevent those deaths. In Franklin County, what we try to do is see that information in real time, see that we have increases in certain at-risk populations, and then utilize that information to get our stakeholders in front of those troubling trends so that we can prevent them quicker. And then, in addition, that information is going to also aid in those public health initiatives as well as community intervention. So when you're looking at the risk factors or just the life experiences of that decedent, this information is going to highlight possible shortcomings within community resources. Where did we miss a connection? Were they involved in a local hospital and we just didn't necessarily ask the appropriate questions related to mental health and suicide? We didn't identify them as an at-risk individual and then say they die by suicide 6 months after that time in the hospital, which we do see a lot. And so when we take that deep dive information, excuse me, I've been talking a lot today. We take that deep dive information and identify that. We then can work through the fatality review, identify that as a recommendation, and then work with our local hospitals to improve the questioning and screening that we are taking place in our community. All right, so now, as I said, I'm just going to shift a little bit and talk about my daily operations at the coroner's office. So as those suicides are reported to our office, I must review and record all of the vital information. So that information that I record is going to include all of the demographics, the injury location, the mechanism that was used, and then also any additional information that's going to help us with determining suicidal ideation and intent, as well as mental illness. Thank you. I keep a spreadsheet of this information, which is used to compare current trends of suicide with previous years. So this isn't something that we necessarily had prior to the year of 2021. But now that I've been there long enough, I'm able to actually compare what we're seeing with suicide fatalities per quarter and then compare that with previous years. So this has been really important to identify these troubling trends. For example, last year we were actually seeing a very, very strong increase in suicide within the Black community. I was able to look at this spreadsheet and see that we were touching the total number for 2022 by quarter 2 of 2023. So we were going to surpass that number by a lot. And I was able to see that in quarter 2 so that I was able to reach out to my stakeholders and say, hey, we have an issue in our community. We need to bring people together. We need to create a call for action and actually do something about this problem. We actually spoke about it when we did the Mental Health Summit for the Black community through OSPF. We brought that number, we presented on it, and we were able to hear from a lot of people with lived experience and really kind of gave our community the approach that we needed to take to prevent suicides within the Black community. In addition to reviewing those cases, while I'm in the office and a suicide death is reported, I'm going to be notified and begin my process to get ready for that scene. A key component of having a suicide specialist in the coroner's office is our partnership between the coroner's office and our local loss team. And so because at my office I am going to be handling everything suicide related, I'm also going to be the liaison between our office and our loss team. And so I'm going to actually contact them immediately when that death is reported to us, and then we'll have a team of volunteers that's also going to be dispatched to the team and help connect with the family. While on scene, I'm going to assist the investigation to a degree that is dictated by the forensic investigator. So I'm just necessarily, I guess, an assistant on scene. I'm not the lead investigator, but when I'm on scene, I'm able to handle every part of the scene. So it just really depends on how the scene is going and what the forensic investigator needs. Some of my assistants can include evidence collection, scene clearing, and then ultimately that communication with the family is something that is kind of my important role. And so a lot of times since I've been working with our investigators, we just kind of team up. They allow me to handle all the communication with the family, making sure that they're connected with those resources, and then collect all the information that we need for the forensic investigation, as well as that psychosocial investigation as well. As I said, once they don't need my physical assistance anymore, that's when I'm going to go ahead and approach those survivors on scene. And I'm going to try to collect as much information to determine that mental health state that they were in, as well as suicidal ideation and intent. Back at the office, I'm going to continue my assistance with suicide cases. So as I said, anything suicide related at the Franklin County Coroner's Office, I'm handling. And this is really important when you think about time constraints of the coroner. The coroners are very, very busy individuals. They have a lot of other tasks that they're completing. And so in Franklin County, I'm able to take everything suicide related and take it off the shoulders of our coroner, Dr. Overmeyer. And he can actually focus on all the other issues that our community is facing as well. And we can make sure that we're taking care of all of those prevalent and troubling issues in Franklin County. But so with my assistants back at the office, we are a scientific facility, meaning we're always going to aim for a scientific means of identification as well. And so I'm also going to help with each of those scientific means. So I can help with the obtaining of fingerprints, radiology, dental, and then ultimately also if we have to go the DNA approach, I can help in that as well. We also have a visual identification process. In times where we have a decedent that doesn't have any other scientific means of identifying that individual, we would then have to rely on a visual identification. This is something that I'm going to work closely with the family. We'll bring them in the office. And I will work with them to prepare them and show them a postmortem black and white photo of their loved one to get that positive identification. This is something that it's important to be trauma informed when you're taking this approach so that you can ensure that the family is safe while they're doing this. And so having someone who's not only coming through it for a forensic element, but also being there from a lived experience perspective and letting them know that although I don't know their particular circumstance, I have went through similar things and I understand the difficulties that come with it. And so just making sure that our office is bringing the loved one, the survivor, to the forefront and making sure that we're making sure that they're okay during their grieving process. I'm also going to complete research to find the decedent's next of kin, and then after finding that next of kin, I will work to notify that next of kin of the death of their loved one. Again, I'm taking that same approach. I'm going to take that notification and try to be upfront and honest with them, but do it in the safest way possible to ensure that they can handle that type of information and that they're safe and have people around them when they are provided with that information. I will also send out subpoenas. And so a big part of the coroner's office and when you're certifying a death is those medical records, understanding what problems and what issues that decedent did face. And so a lot of times I'll actually send out the subpoenas, collect all of that information so that I have everything in front of the pathologist that they need to make an accurate and confident certification of that death. When I don't have any active scenes, I will conduct follow-up calls with the survivors that I'm working with. And so these follow-up calls are just kind of check-ins. Like I said, I take it really, really seriously when I talk about I'm trying to walk alongside them in this grief process. And so throughout all their involvement with the coroner's office, when they're talking about funeral arrangements and things like that, where this could be something they've never experienced before, they don't know how to look into funeral homes, they don't know the process. Making sure that I'm there with them through that entire process, answering those difficult questions, is also really important to me. In that process, I'm also going to make sure that everything that we need on the scientific side of things is completed too. So it's kind of a two-part, making sure that they're okay, but then also getting the information that we need in the safest way possible for the survivor, making sure that, again, they're in the forefront of my mind when I'm navigating all of these tough and difficult conversations. I will also follow up with family for cases that I was unable to attend. In Franklin County, we can have anywhere between 170 to 200 suicides per year. I'm one person, and I can't necessarily attend every single one of those suicides. And so our forensic investigators will go to the scene as they would any other day. They just wouldn't necessarily have my additional hands for assistance. But now that I've worked with them, for quite a bit, they know what information that I'm looking for as well. And so having this unique perspective has also changed the way that our forensic investigators themselves are investigating suicide deaths, which I believe as an overall has improved a lot of those the quality of those certifications, and have led to our pathologists feeling way more confident in certifications of those. But in those times, they will also let the family know who I am, and that I might be reaching out to make sure that they're doing okay and kind of walk alongside them. So this is a way that I can then follow up with them after, conduct that follow-up call, do it the same way I would do if I was on the scene, making sure that they have resources. And then I would conduct the psychosocial interview via the phone. We can do it in person. I've met family members in certain spots, just whatever works for them the best. But this is a way that even though I'm not able to go to every single one, I am trying to have my hand and be there for every single family member who's now experiencing this tough grief that I've mentioned many times at this time. Once I complete those full psychosocial interviews, I'm then going to complete a full psychosocial report, which is what I utilize on the suicide fatality review. So that full psychosocial report is completed with information gathered from those interviews with the survivors, the friends, people who've been impacted by that suicide death. But I'm also gaining information through public record, social media, medical records, any other news or any other outlet online that I can find available information related to the decedent so that we can have a better picture of who they are and what they've experienced and what led them down this unfortunate path, so that we can then present on it in the fatality review and create changes within our community to prevent a similar situation from happening again. That report is broken up into sections which provides unique details about the decedent. I'm going to investigate stressors that may be present within someone's social dynamics, religion, education and occupation, substance use, mental health history, physical history, really any stressor that may not even fall within one of those categories, but it lets us understand what may have impacted the path of this decedent's life. I touched on it a little bit when I was talking about the certifications of death. And so a big focus for me outside of being there for the family is the equivocal death analysis. So there's a lot of coroner's offices around the United States where equivocal death analysis becomes extremely important. There's a lot of times where a pathologist will be looking into a case and they just don't necessarily have enough information to feel confident in certifying that death, a suicide, an overdose. A lot of times at our office we have a common profile that we call as an ambivalent suicide. And so a lot of times this is a situation where we know the cause. And so we understand that it could have been an overdose of some sort. We've got the toxicology back. We have the substance. But there is a long history of suicidal ideation with this decedent, as well as a documented history of substance misuse and some accidental overdoses, as well as some documented non-fatal self-injury incidences as well. And so in those moments, a pathologist might not feel comfortable in certifying it one way or the other. And so a big focus for me is trying to take that deep dive into that decedent's life, trying to pull out that information to create that confidence for the pathologist. And a lot of times, when we're doing this deep dive, we're unable to find that suicidal intent, and that will allow that pathologist to feel more confident in certifying that death as an accident. And again, it's important that we have it certified accurately, even if it is an accident, so that we're informing the public with appropriate and accurate data sets related to accidental deaths as well as intentional deaths as well. Community involvement. So this is another way in which I'm helping out Dr. Overmeyer, our coroner, as much as possible. So again, we have a lot of issues that we're facing in Franklin County, and a lot of times our coroner is in the forefront of that and doing a lot of work when it comes to prevention and things like that. So in the world of suicide, I'm able to then take all of that and go out into the community and represent our agency. I also have provided education and training for other coroners and medical examiners' offices, as well as other public health departments regarding suicide death investigation. And so to date, I have interacted with and worked with about 15 different states when it comes to their death investigation process, and attempting to just help them as much as possible to create more confidence in their suicide death investigation. I also work with those states who obtain additional funding for suicide specialist positions such as mine to help improve their suicide fatality review process. I have also partnered with multiple agencies and publications. So I have worked with the Suicide Prevention Resource Center to publish national recommendations for local suicide prevention infrastructure. I was able to help on our review manual that we all have in our folder here. And then lastly, for community involvement, I also sit on many boards and committees to continue help our local strategies. So I sit on the board for our Lost Community Services to help increase our community's capacity to handle and work with individuals who's lost a loved one to suicide. I'm also a part of the Ohio Task Force for Criminal Justice and Mental Illness, where I try to assist our community's capacity to work with individuals who find themselves within the criminal justice system, but are also battling a lot of mental illness and suicidal ideation specifically. And so I try to work on how we can connect that individual to services while they're incarcerated, but also when they're released to continue that path of success. And then also I sit on the advisory committee as well as the data and research action team through our Franklin County Suicide Prevention Coalition, where it's kind of my obligation to help increase our data transparency, and I also help with the Franklin County's annual strategy for suicide prevention. The idea of prevention in a medical legal office. So this isn't necessarily a new topic. It's been something that's been covered several times, and there's actual several studies and articles on this topic. They talked about the possibility of embedding social workers into the coroner's offices to work with individuals related to trauma that might come from violent deaths. We've also talked about the fatality reviews to develop those recommendations, as well as epidemiologists and statisticians on staff to evaluate the data that is available and help with our community interventions. Our coroner's office in Franklin County, Ohio, we have worked to incorporate all three of those situations. Now, we don't have any social workers on staff specifically at the coroner's office, but we do work with many outside agencies and partner with them so that we can connect our families with them, such as Net Care Access or Lost Community Services, just so that they can have those resources moving forward. We sit on many different fatality reviews. And then also we have a statistician on staff who his sole position is to look at all of the data that is available to us at the coroner's office so that we can easily inform the community on the trends that we're facing. Turning postvention into prevention. So Tony Coder, the executive director of the Ohio Suicide Prevention Foundation, and then the former Franklin County coroner, Dr. Ortiz, they were both extremely passionate about suicide prevention. Their willingness to come together for this cause and create a position such as mine has truly changed the way that suicide is approached. In Ohio, coroner or medical examiner's offices are government-funded entities. And so historically, when you look at government-funded entities, finding funding for new innovative ideas can be difficult. And so when your local boards won't fund these types of things, you have to then start to think outside the box. And that's what Tony Coder and Dr. Ortiz did. Tony said, we do have some leftover available budget. I can look into possibly providing a grant to the coroner's office to have a position such as a suicide specialist to take a deep dive into the situation and see what we can do about it. And that's what they did. And so my position is grant funded through OSPF, but I am stationed in the coroner's office. And so I have all of the protections and subpoena power and all of that the coroner's office would have. It's just my salary and the things like that is actually funded through the OSPF budget. Traditionally, the coroner's office is going to be more in the realm of post-dementia. As the population that we serve has unfortunately already passed on, but when we implement positions such as a suicide specialist, where we can find this information and then speak about it on a fatality review, we're actually taking that post-dementia approach and turning it into that prevention. We're actually identifying things that are issues in our community and then doing the work to get out in front of them and make actionable change to prevent future suicides from happening. My next point here is extremely important, and that's why I've underlined it. And that is that we must see the continued implementation of the recommendations that come from a suicide fatality review. Although all the conversations and everything that we do on a fatality review is important and it's great, empowering conversation, until we actually have it implemented into our daily operations and have other stakeholders and agencies do the same, we're not necessarily going to see that actionable change. But once we do that, we create that united front that's necessary to tackle the issues that are prevalent in our community. And then lastly, I just want to touch a little bit on how I also work with our coalition. I said this a couple times through pretty much all of my presentations, but they're really important to the work that I do in Franklin County. And so I just want to touch on them real quick. The Suicide Prevention Coalition is actually the actionable arm for the Suicide Fatality Review in Franklin County. And so once our recommendations are created, we then report them to our coalition, and then we utilize the 3 action teams of communication, education, and data and research to categorize the SFR recommendations via social ecological model, and then actually create a tracking system to track the implementation of those recommendations into the community. That's still not necessarily a work in progress because we just got them as an actionable arm in the last couple of years. But having them involved and having all those different perspectives and expertise has really improved the implementation as well as just the quality of those recommendations. And that's it for me, so I'll pass it over to Austin.
All right, thank you, Dallas. And I know many communities are kind of jealous of Franklin County in that regard. A lot of people want a Dallas just because, as you heard, he can do a lot of things. In terms, especially at the coroner's office, has kind of a lot of that ability to go out and get all this information as soon, right beginning at scene response all the way up into follow-up investigations and work. But what I'm going to talk about is, what your fatality review board or what your community can access that is not necessarily as comprehensive as Dallas's position. But a lot of communities do have access to somebody who's a certified psychological autopsy investigator, or if they don't right now, could access somebody who is trained to kind of perform these types of more thorough investigations and can really help you supplement your fatality review work. So that is what I'm going to be focusing on a little bit here. So what we know is that psychological autopsy investigations investigate further. They really just take that deeper dive into a decedent than maybe a suicide fatality review board can do. So a PAI, or psychological autopsy investigator, is typically one person who goes through, again, kind of this rigorous training to learn how to take that deep dive and actually review all of the associated documentation, all of the reports, all of the systems that the decedent was involved in prior to their death, and and really come together and take a look at more of, the why somebody died by suicide. But again, take a look at where are some of those points of intervention or gaps in systems and services that, the actionable arm such as the coalition could implement in the community. They typically happen sooner after a suicide loss. So you heard Dallas say that, typically he starts pretty much, at the scene and then continues to go on. A psychautopsy investigator, again, especially if the psychautopsy investigator is not an employee of the coroner's office, they really wouldn't have that ability necessarily to go right on the scene there. Psychautopsy investigators, again, usually 3 to 9 months post-mortem there. Again, procedure to understand the why and also some other factors as well. And kind of what we've been working on in Ohio. And again, thanks to funding from the Ohio Department of Mental Health and Addiction Services, is to train, a fairly large number of folks to become psychautopsy investigators. But also what we've learned through some of that SAMHSA VA work that you heard Kaylin earlier talk about during that virtual presentation right during the opening remarks, is that Ohio is unique in the sense that we're actually trying to, again, incorporate these psychautopsy investigators into the operation of local suicide fatality review boards. So this really is kind of a novel approach here in the field of fatality review. And SAMHSA and the VA continue to invite Dallas, myself, and also Denise Minagram, who's also here as well, to talk about loss teams, just because they understand that this is a newer approach, and they see it kind of as a best practice. And I'll talk a little bit more of why we are making this recommendation. So again, what goes into a psychautopsy investigation? I talked about how it goes a little bit further than, say, just kind of your general fatality review board. And again, I'm not saying that you need to have a psychautopsy investigator. As you've learned throughout today in some of the breakout sessions, there are plenty of counties that are doing great work that do not have access to somebody with this particular certification or training background. However, we know that the report and the investigation that a psychautopsy investigator is looking into, all death information, again, provided from the coroner, police reports, physical autopsy reports, witnesses, right? Not just next to kin, but also who are those family members, those friends, those neighbors, coworkers, colleagues, things like that, that may have known the decedent, especially, soon, right before the person ended up taking their life. Demographic information, medical history, SUD history, mental health history. And also, by the way, what we are recommending is that folks who want to bring in a psychautopsy investigator, and I'll show you in a minute where they're located in Ohio, who we've actually certified, so you can just kind of take a visual look at that. But what we are recommending is that the psychautopsy investigator actually become a true member of their local suicide fatality review board, so that they can receive some of that immunity, that protection against litigation and liability and things like that. Kind of, again, what you heard earlier this morning from Socrates from the Ohio Department of Health, right? So that is why we are making that recommendation. And you probably heard me ask the question too about the compensation piece. Again, I think that helped clear things up there, that somebody performing a psychautopsy investigation for a suicide fatality review board cannot receive any sort of payment for that work, right? So again, that's why most of these folks that we've certified, it's kind of understood that this should be a part of their regular job position, right? Just so they're not receiving any sort of direct or outside compensation for that work. So again, what else goes into a psychautopsy investigation? Just again, those last points of care or contact are really critical, right? For example, and I've heard a few examples thrown out throughout the day, regarding, like medical systems and things like that. Say somebody was seen at a local hospital, found out after the decedent died that the hospital does not do universal screening or conduct universal screenings for folks, right? Again, was this the last point of contact for this individual, right? Taking a look at that. And there's other systems as well, right, that the decedent was involved in. And more importantly, which again is along the same exact vein as the ultimate goal of the Suicide Fatality Review Board, is how finding suggestions or recommendations, right, on how similar suicides could potentially be prevented, right? That is what comes at the end of the investigation for the psychautopsy investigator, but that is the ultimate goal. So where are the psychautopsy investigators located? So in 2020, I mentioned that we received some initial funding from the Ohio Department of Mental Health and Addiction Services to train up to 100 folks in psychautopsy investigation. Of those 100, I think it's 74 went on to become certified to do the work. There were 2, I was one, and then somebody else as well who was certified prior to this funding. But here they're at. Here are where they are at. So pretty good spread around the state, right? You notice that not every county has representation there. Also, we have surveyed some of the folks that have been trained in psychautopsy investigation, and maybe they've moved on from their position, right? But that number is not at that same level as it was of 74. So we do have plans, and I'll talk about that here in a minute, to offer a very similar training to psychautopsy investigation for other folks in Ohio, so we can keep this work moving forward. So earlier this year, we funded 5 psychological autopsy investigators who were certified under that initial 74 to actually do a pilot investigation for us. What we wanted to hear was, again, what were some of those common barriers, right, that the psychautopsy investigators actually encountered while doing this work. The ultimate goal, and I know that some of them are here today, sitting in the room, who were part of that pilot project. But just know that I will be reaching out to you sometime in the near future to do some more in-depth follow-up. So to create, hopefully some lessons learned, best practices for future psychautopsy investigators to showcase, again, this work can be done in the state of Ohio. And here are some kind of lessons learned from folks who've actually done this work and how they've engaged with their existing Suicide Fatality Review Board as well. Which moves us on to my next point. So I mentioned, future training in Ohio around psychautopsy investigation. So, we previously worked with the American Association of Suicidology, or AAS, for this training. They've moved in a different direction in terms of this training. So we have consulted with some extremely professional folks who kind of work in the field of death investigation across the country. And this training is called Retrospective Fatality Analysis, or RFA. We're actually going to be providing this training to a cohort of 25 folks early 2025. It is basically another version of psychological autopsy. However, this training, from what I've heard, is they take special consideration for interacting with suicide loss survivors, which we know is very critical to this work. And I know that some folks have talked about interacting with the loss teams. You heard Dallas up here talking about that. So again, just taking special care of those who are left behind, right? Because they're extremely vulnerable in this work, as many of us know. But again, this training, this new procedure is developed by a multidisciplinary team of 7 highly experienced death investigators and suicidologists. We believe that coroners, death investigators, mental health boards, and health departments are all great trainee candidates for this training, just because, again, we already heard from Dallas. We know the importance of, why we think that those who work in the coroner's office or under, medical examiner's office would be perfect for this work, just because, again, they have that subpoena power and they can go unseen, right? However, we also know that mental health boards and health departments, they are required per the statute, right, to be to sit on a fatality review board, right? And so for those reasons, we believe that those are some really great candidates as well. You don't necessarily have to have a clinical background to take part in this training. It will kind of go over, some of those foundations in this training, and interviewing skills and things like that. But again, kind of one of the key themes in this training is the special care for those loss survivors. And again, also this, if you are trained in RFA, it could help in equivocal death situations or determinations, right? Of course, that would be kind of up to, working with your coroner's office or your medical examiner's office to kind of, figure out if you would be used in that capacity. But for the purposes in Ohio, what we are trying to encourage is for prevention, right? Community prevention work, learning what those gaps were in the systems that the decedent was involved in, and then using that to inform those local recommendations, and some of which you have heard from Dallas talk about, and also earlier presentations from Daniel and the folks from Hancock County as well. So, I mentioned the cohort of 25 folks who are going to be participating in RFA. So here are the counties that are covered. Again, fairly nice spread. They're not in any one central location. We're not just solely focused on Central Ohio, right? We're very intentional about picking these folks. And these folks that and this is just the initial cohort, right? There very well could be additional trainings, but this is just kind of the first group of folks. What we did as a part of an application process to make sure we picked the right people to take part in this RFA training is, we ask questions like, again, are you already part of your fatality review board? Do you have a relationship with your coroner or medical examiner's office or in your coalition, your loss team, so on and so forth? But one of the big things here was to get a letter from their employer saying, I understand that this training will be used as a part of my employee's regular job to conduct periodic psychological autopsy investigations, or in this case, retrospective fatality analyses as part of their job. So again, we want to ensure these folks will actually do the work, right? Because we know that it's extremely valuable. So, I already mentioned, kind of our vision is to integrate those psych autopsy investigators with the existing and also the growing, right? All of you, the growing suicide fatality review work across the state. So, I mentioned, that survey, when we surveyed some of the previous psych autopsy investigators that got trained, we learned that some of them have dropped off, right? They moved on to a different employer and they can't, conduct this procedure in their new capacity, so on and so forth. However, there were some themes because we also at the same time surveyed some of the existing suicide fatality review boards across the state and asked very similar questions. And one of the themes that coexisted there is that the majority of respondents wanted to collaborate with each other and learn more, just because they do value, well, first off, again, a psych autopsy investigator just goes that much deeper, and it's extremely relevant to that work of the suicide fatality review work. Again, PII investigations investigate further into psychosocial history. I already mentioned they happen typically a little bit sooner than a suicide fatality review. However, there is not just like one general, agreed upon time to reach out to the family and start collecting these records, conducting these interviews. However, there is kind of that general time range that is recommended for both a psych autopsy investigation and then also, a time range for reviewing a suicide, under a fatality review board. And we know that, and like I said, SAMHSA and the VA definitely recognize this. We know that integrating both together really does have the potential to improve the local suicide prevention, intervention, and postvention initiatives in the state of Ohio, and also beyond, right? And also at the state level too. So, I know that we don't currently have the results of those annual reports that have came into ODH just because this work is so new. But the more that this does happen, and the more counties and regions that implement suicide fatality review boards on an ongoing basis, the more reports that go up, and the more we can learn at the state level too about where the need is the greatest, right? And where some of these pockets where we might be seeing some of these specific trends in particular communities, and where we need to deploy, additional resources. So what are some of those benefits to integrating both psychoautopsy investigators, with the work of the Suicide Fatality Review Board? We know that, you might be asking yourself, well, it sounds like a psychoautopsy investigator just goes that much deeper. Why not just have a psychoautopsy investigator instead of a fatality review board? It's because we still want the members of the local community in the fatality review board, because they probably have a lot more information about, their particular systems that they work in and kind of the particular needs at the local level, whereas a psychoautopsy investigator might not have that particular knowledge about some of these systems locally, right? Or they might not even be from the area, right? For a very particular case that, that might seem a little sticky, you might want to call a psychoautopsy investigator from somewhere else in the state. And again, they really wouldn't have any of that local knowledge that is extremely vital to the operation of a successful fatality review. And again, those local organizations might actually represent the background of the decedent too, right? These are systems that actually the decedent might have been involved in, right? Where the psychoautopsy investigator, that's probably not the case. And like I mentioned, the psychoautopsy investigations, or RFA, right? I'm going to use that interchangeably. We've talked about psychoautopsy investigation and called it that for quite some time in the state of Ohio. So I'm just going to continue with that terminology, even though the new procedure that we're going with is called retrospective fatality analysis. So what are some of those next steps in the state of Ohio, and how can you get involved, right? So what we're currently marketing now, again, there are a few, and I emphasize the few spots left in that January RFA training for folks. So if you're interested, or somebody who's interested, and and are employed in some of the systems I mentioned earlier, like the coroner's office, the mental health board, local mental health board, or health department, please come up to me. I encourage a conversation around this. But participate in the RFA training opportunities. That first one, again, is in person. Actually, it's literally here in this building. We'll be back here again for that RFA training, January 23rd through 24th. It's a 2-day training, all-day training. And also in RFA, too, they emphasize the mentoring opportunity. So not only do you receive this training, you have to become certified through retrospective fatality analysis, meaning you have to actually do a real case investigation, a real one in your community. And if you can't find one, the trainers can help you identify one, and they can actually mentor you through that actual investigation process to do your first one. And I know some folks in this room might have participated in previous iterations of the psychoautopsy training, and we know that that is something that that we've heard from folks. Hey, we wish we could have reviewed a real case, right? So in this training, you do. I also encourage you all to familiarize yourself with the new Ohio SFR manual. We know that this is not the end-all, be-all resource for you all, however, and also we're not trying to say this is what you must do, right? These are just some great tips, about what we've seen work in some communities across Ohio. I really encourage you all to take a look at the appendices in this manual, because there you'll see some of the actual forms that we kind of put together based on what we thought were great examples of, I'll just give one example, like a SFR member recruitment letter, right? Recruiting new members. There's a template in there for that. There's also kind of this, toxicology template as well. Again, just great confidentiality agreements, right? So I encourage you to take a look at that, modify it, adapt it, whatever you need to do to kind of fit the needs in your community and what works best for you all. But also, we are working on creating fillable PDF versions of this that will be made available as well. I know that it'll be available, by either with ODH or on OSPF's website. So we're still working on that. And I was told earlier today that the SFR manual is digitally on the Ohio Department of Health's website. Just went live. So if you need help finding that, you can come talk to me. So again, if you do currently sit on your Fatality Review Board, or you are the facilitator of your Fatality Review Board, I recommend you reach out if you're interested in locating or kind of introducing. I can probably make an introduction to a local psych autopsy investigator if that's a conversation you're willing to have, and see how that partnership or that relationship could work in your community. And again, something that we're also working on is kind of this creation of standard consent forms or templates and record request forms to conduct interviews and reviews. Some of that in which is already in that manual there, but particularly for the psych autopsy investigations, that is kind of on the next step list for resource development. But with that, that formally concludes my portion of this. We have probably about 9 minutes left for some general Q&A for both Dallas and I. So again, thank you. Anybody have any questions kind of right off the bat? I know that Dallas's position's pretty attractive, so I'm sure some folks could come up with some questions.
I can be loud if you want me to.
Wait, actually, we want the mic because we're being recorded and stuff, so. Yep.
I am, actually. Hi, so we are doing a combined OFR SFR, and one of the things that we've kind of gone back and forth on is getting information for clients if they've been seen outside of our county. So coordinating with, well, first of all, finding out where they've been involved, but let's say it's someone who's unhoused and we don't know what their previous addresses were. So is there a way that you've been able to figure out first where someone has been engaged or where they've been treated or where they've been seen? And second, engage those agencies in getting information on your decedents?
Yeah, so there's actually been times where we'll have a decedent and they die in our county, but they're actually from a different state as well. And so we have a lot of colleges that are local in our county, and so we have a lot of people who will come from out of state, and that event would happen in our county. And so it comes down to, okay, probably most of their connections have been in a different state. Unfortunately, some states do have things in place that say that they don't have to comply even with our subpoenas that we send from the coroner's office. So unfortunately, those times are just, we have to figure out, did they have connections? And so we have looked at what was available. So like, what connections did they have at the university? What connections did they make here in our community? Just because we can't, unfortunately, due to the law that they had in that particular state, we couldn't get it. Now, within the county, Franklin County is a little bit unique because we do have that subpoena, and so even if it was a different county, they still have to comply with our subpoena. Now, from a perspective when maybe you don't have that, you could possibly do like consent, like a release of information from a family member or next of kin that you then can provide to that agency, in which you had that consent from the family member to release that information to you. I've seen that actually work in some communities, and they'll just say, hey, we know that they've had involvement here, and then you could just, while you're talking with the family, say, hey, we would just really like to see what that involvement was, and have them sign off on that release of information. Just another way to go kind of, it's kind of like a subpoena, but it's just not the full subpoena, so.
I know it's been a long day, guys.
All right. You guys close us out. Mic drop. Thank you to our speakers for presenting, and thank you everyone for attending. If you need CEs or a certificate of attendance, please write down the following code: 8964 8964. If this is your last session of the day, please make sure that you have a staff member review and sign your CE certificate. I can do this for you, but any conference staff wearing a yellow Life is Better With You Here t-shirt can do this as well. We'll also have staff at the registration table. Finally, if you're seeking CE credits in Ohio for social work, mental health counseling, addiction counseling, prevention, or psychology, you'll need to attend both breakout sessions today and complete 2 copies of your CE certificate. Both will need to be signed, and one will need to be turned in to the conference staff or volunteer. You will take the other copy home. See the directions on your CE certificate for more information. Thank you.